Is Dr. Ranjan Rai. So when OT is ready, we'll stop the discussion on vitreoretina's part and then we'll move on to phacoemulsification and anterior segment surgery. In the meanwhile, yeah, please. So the second surgeon is dynamic Dr. Ranjan Kumar Rai, director of Patliputra Netradam Eye Hospital, and also MD from All India Institute of Medical Sciences, DNB, ex-assistant professor of RIU IGMS, senior consultant ophthalmologist, a dynamic surgeon, also director of Uddhav Balaji Eye Hospital at Siwan. Let's hear from him. Fortunately, he has now become very healthy after getting admitted to Medanta. So I think all the best, Dr. Ranjan.
Thank you, Dr. Vibhuti.
For coming out of that illness and then again deciding to come and do the live surgery is wonderful. So go ahead and all the best.
Thank you. Hi everyone, as Vibhuti said, I am Dr. Ranjan, and this case is of around nucleus grade 2-3 and बहन जी बत्ती को देखिए
So
बत्ती को देखिए.
The age of patient is 54, female. Yeah.
Patient is under anesthesia for half an hour before, so he sees little bit uncooperative.
So the left eye visual acuity is 1/60, K1, K2 is 43.58 at 63 degree, and 43.90 is 153. So basically it is a spherical surface. So astigmatism is very minimal, 0.31 at 51 degree. Axial length is 23.64 and IL is 21. So Dr. Ranjan Rai will be putting Clarion. The second eye is phakic in this case. So please go ahead, Dr. Ranjan.
I just put this phenocane because this patient is little bit uncooperative. She is under topical anesthesia. Incision planned in this case is at 105 degree. I am waiting for the phenocane to get its work done so that patient as well as surgeon can become more comfortable. So it is always better to give some extra time when the patient is under stress. This is for PG, this is not for expert surgeon who are sitting there. Keratome. And in the meantime, I am going to make this main incision. Give me some bud.
So usually how much time you give for trypan blue to work on the
30 seconds to 1 minute.
Okay.
So in the meantime, I used to make my main incision. As you can see, it's bleeding little bit, so it is nearly little bit limbal incision. The reason for bleeding is just to enhance the healing little bit faster after the surgery. So now main incision is complete. It is almost 3 planar incision. Saline, BSS. And I used to wash it with थोड़ा सा visco डालो cornea पर. This. So some water pooling is there. So all these factors should be taken into consideration during surgery for the beginners. These are all small steps, but if you are not taking care of these small steps, this is going to create some visual problem for you during surgery. Now I am injecting HPMC. Though it appears to be little bit high vis खोले हो viscot high vis कुछ खोले हो क्या? So This is very beautiful microscope actually. First nick, waiting and looking up for this direction of the nick, and now inverting the flap, raising this flap, again waiting, looking for the proper direction. Here I thought the Rhexis is going to be small, so I enlarge it little bit in the periphery, and now again continuing this Rhexis. So by this way my Rhexis is now almost complete. So it is around 4.5 to nearly 5 millimeter Rhexis. Hydro procedure is equally important. Before putting any further fluid inside the anterior chamber, you should decompress this and remove some viscoelastic. Just go inside, uplift the Rhexis edge and do a gentle hydrodissection.
Ranjan sir, did you use any viscodispersive agent for Rhexis?
No, it's HPMC.
Very beautiful Rhexis you have made.
Yeah, it's a very beautiful Rhexis, Dr. Ranjan sir.
Sir.
And you always take it anti-clockwise or a clockwise while you do the Rhexis?
Right now, what way I have done? Can you tell me? Is it anti-clockwise or clockwise? I have never noticed it.
It's anti-clockwise.
So
what are the advantages of doing clockwise or anti-clockwise? Anyone?
So now,
I think it depends on the right or left-handed person.
Yes, sir. Of course, it depends. But in anti-clockwise, sometimes there comes a blind spot.
Chopper.
So it's always good to do the clockwise, because when you come across the blind spot, you miss the Rhexis.
So being lefty, I always do anti-clockwise. Let's be fair about it.
Most of us doing anti-clockwise. Yes.
Always prefer to rotate the nucleus with the two instruments, just to reduce the stress over the zonules. So now this rotation part is complete. Now I need viscot. At this stage I am injecting viscot, and I am HPMC, double cell टेक्निक. बहन जी बत्ती को देखिए. कोई दर्द हो रहा है क्या आपको? सुन रही हैं? दर्द हो रहा है? नहीं ना? तो आधा ऑपरेशन तो हो गया.
So what Ranjan sir just did is he just coated the endothelium with the viscodispersive agent, and then he has put the normal HPMC. So this is also a preferred technique in such cases.
So I think in this case, few weeks back we had a great surgeon from Odisha. He did Phaco without Phaco. He was very excellent surgeon, but I don't think that clean karo cornea ko. IOP घटा दो तो IOP 50 कर दो.
So what is the guide for control of IOP, Dr. Ranjan? Please complete your shop, then we can discuss.
As I have gone inside, the AC has suddenly become more deepened.
Okay, so you reduce
So,
the IOP,
IOP,
for.
huh. So what I have done, you can see the parameters for this kind of cataract. This is my parameters for chopping. Is it focused?
Yeah, it's focused.
Okay.
Don't worry. Please go ahead. Beautifully divided into two parts, and now you are trying to hold for third chop. Yeah, so now it is nearly 3 parts.
This is the step where you should be careful. माइक्रोस्कोप फोकस नहीं है जी थोड़ा सा.
So there is a little bit of lateral separation you also do at the end
Yeah.
of the end of. So
It's kind of mixed chopping technique. Neither it is pure horizontal nor it is pure vertical.
but the main aim is to crack it completely to the last fibers, and that is most important thing.
Viscot though. This is the step where you should be careful. Viscot. Now you are going to be in the rough sea. You are going to damage endothelium after this stage. So it is always better to coat the endothelium again. Quadrant. So I am taking some time to look at my Rhexis to the chopped pieces whether they are separated or not, and now you can see this beveled end sideways. This is just going to provide me more surface area for this emulsifying this nuclear fragment. And though people used to say inside the bag, but most of the phaco procedure are at the iris plane level, and see this my left hand is just supporting the nuclear fragment to stop this inadvertent movement and turbulence. This last piece, again, I need some HPMC or viscot kind of thing. Region is 2. This is going to give.
Dr. Ranjan, once you turn the phaco probe, you will see that the first point of exit of irrigation is pointing towards the endothelium.
Yeah.
So while you have more space in, you're getting a good hold, will that exit point of irrigation not hurt the endothelium?
Yeah, that's very true, sir. That's very true, but doing this, this is already a bevel tip. So like this, I am at the parallel to this iris plane or Rhexis margin plane. While doing this, this angle is going more towards in this posterior capsule. So at the last piece, if there is sudden surge due to any reason, chance of hitting the PC is more, sir. This is my personal, I may be wrong. I may be wrong. I may be wrong, sir, but some habits used to be since very initial teaching.
So the flow rate is 38, and that's why there was. Yeah, wonderfully completed this phacoemulsification. I think, yeah, that point need to be taken into consideration, that the flow should be on the side, so that the actual convection currents are bringing the nucleus chunk towards the tip rather than taking it somewhere else. But with these machines and the way you coated the endothelium in between also, that is going to give added kind of support system. Howsoever, the point was well taken that the
Swabistic. क्या दे रहे हो हमको?
Irrigation ports should happen on the two sides.
Bimanual. Ranji, Pheno can देना.
So we also just observed that Ranjan sir, before coming out of the AC, he just maintained the AC with the viscoelastic and then came out of the AC. So this is very important step, especially in cases of where you get compromised PC, like if you get PCR, then it's very important to come out after maintaining the AC and don't just suddenly come out.
Abhishek, a lot of surgeons have moved on to hydroimplantation. They are using less and less viscoelastic.
Cortex karo, cortex.
And that is what I was discussing with Subhash sir last time, that if you are trying to do hydroimplantation and you come out, and if you again have to put viscoelastic to maintain the anterior chamber, then the whole purpose is defeated. So what do you do at that point of time if you are trying to do hydroimplantation and you still don't want the anterior chamber to collapse?
So,
are you asking in cases of compromised PC or normal cases?
No, routine cases. Routine cases, you want to use as less viscoelastic as possible, but at the same time, you don't want the anterior chamber to collapse each time you are coming out.
So it's always good to do the stromal hydration before entering into the anterior chamber.
Yes.
And there are another advantage of coming while you come out from the anterior chamber. So sir has put the viscoelastics. So one is to prevent the PC and second is to the unstable anterior chamber, so that it will prevent the inadvertent PVD or even in later stage the PVD occurs.
It has occurred on table, and surgeons have complained that suddenly the glow has disappeared and there is some vitreous hemorrhage. So probably that is why we don't want the anterior chamber to fluctuate even a little bit. So you said that we should do stromal hydration when we come out.
Yeah, in fact, if you are doing any kind of a hydroimplantation or thing, so if you do even in a toric IOL, if you do the stromal hydration before entering into the anterior chamber, your AC will remain relatively stable.
But will it not cause repeated stromal hydration, will it not cause any problems in the visibility?
No, you don't do a lot. Even stromal hydration, if you do only along the incision, it will not impair the visibility.
I think stromal hydration in between surgery is needed only if you have got a leaky side port or the main port. If your ports are well formed at the beginning of surgery, then you can just judge it during the surgery that what is happening to the anterior chamber, whether there is a tendency of sallowing regularly or is it maintaining the level of depth when you are coming out of the anterior chamber. And that point that is the pointer towards making hydration or no hydration or putting something.
Normally it's almost well formed, but sometimes we do get leaky AC and we need to do it like maneuvers like this. Deepak sir, have you...
When you take the Phaco probe out, anyway you are on position 1, that is irrigation. So your anterior chamber is already filled with, BSS. So you are saying that you do stromal hydration with one hand and then you come out?
So some cortical fiber remnants are sticking to this Capsulorhexis edge and posterior capsule. So I am implanting the lens, then after I will try to remove it. And lens I am implanting is 21.5 diopter
Clarion
platform as the company claims that it is having minimal PCO, almost 99%, it is PCO free, glistening free, and added advantage is it is going to give this 66 centimeter of this functional near vision. And I am going to inject this lens with the wound assisted, but isko rakh lo, keratome do. But my thought is keratome. Better to little bit enlarge this 2.2 region, better not to rag this main wound. So make your insertion little bit more smooth while you are injecting it under the BSS.
So you're putting it under BSS?
Under BSS, and I always enlarge little bit of this my main incision. Now it is easily accommodating the and this is my limit. You can see this IOL coming beautifully and it is very smooth. It is almost without any pressure. It is directly going inside the bag. So this is the way how one should consider the IOL implantation under. बहन जी 3 बत्ती दिख रहा है, कैसा बत्ती दिख रहा है 3?
Good morning, Dr. Ranjan.
Good morning.
So, what I was telling that you are advocating for increasing the incision a little bit, na?
Little bit, yeah.
So, what advantages do you get doing this?
बहन जी 3 बत्ती देखिए. Advantages, sir. When your incision is tight, this cartridge is going to fit very snugly, and you have to exert little bit extra pressure. Under water, to get the better control, it is better to go with not with the exactly 2.2. You can go by 2.3 or 2.4 to make your. बहन जी बत्ती को देखिए. Cortex. Now it is safer for me to remove this cortical remnant. These parts. बहन जी बत्ती को देखिए. So I think now patient is becoming a little bit more impatient, and I too. So I think the visual axis is clear, central 5.5 millimeter of this optical zone is clear. So few cortical fibers are there, I can leave it. I don't think it is going to do any visual hampering in the future. Thank you, sir. Thank you for patience watching. Any question? Most welcome.
No, first of all, let me congratulate you. Batted like Rahul Dravid, stayed on the pitch for long duration to show the nuance of or the finer steps also. So wonderful demonstration of a skill and technique also. Big congratulations to you, and I must say everyone also clap for Dr. Bholesh Ratna. He did a wonderful vitrectomy and we forget to clap for him. So for this clap was for Dr. Bholesh and Dr. Ranjan.
Yes, sir.
Yeah, once you have completed, then we will bombard with you few questions.
Most welcome.
But wonderful demonstration of technique.
बत्ती देखिए बहन जी, जोर नहीं लगाइए.
Beautiful Rhexis, which is covering the IOL very well.
Patient is now straining, so this. How many of you are going to give this tablet acetazolamide before phaco surgery?
Question we have to ask.
No, not antibiotic. I always keep this tablet, acetazolamide 2 tab, 1 hour, 1.5 hour before the surgery.
So let be very fair. If patient is myopic, usually I avoid giving any kind of acetazolamide or some kind of medication to reduce the IOP and shrunken the vitreous body. But in cases of hypermetropic eyes, shallow AC, usually we give. It's not a very routine kind of prescription, but yes, we have to judge that. So you were operating on number 1, Luxor Rivalia.
Yeah.
So I'll ask the advantages, what you felt here, number 1. But let me congratulate you again on one more thing, that your control of hands was excellent, because the way you were putting this viscodispersive device inside the eye when changing the hands, it was wonderful.
Yeah, so I am so proud to be standing next to Dr. Ranjan. He had done so well, despite not keeping very well for last few days. So big thank you to Ranjan
and
demonstrating a skillful surgery. So now whatever question you want, you can have him for another few minutes till the time this patient is prepared.
So what advantage you felt was there on this microscope? You are operating on another microscope at your own place.
Chashma de do mera na chashma.
Sir, when Ramamurthy sir is ready, just let us know so that we can learn little bit.
See, this microscope is really good. The depth is better compared to other microscope available in the market. The red glow is fantastic. Though even the patients were moving up and down, patients was a little bit less cooperative, but throughout the surgery I am able to operate under the red glow. This is one thing. And depth, I can see the 4 micron thickness of posterior capsule throughout the surgery and 8 micron thickness of Bowman's Desmond complex throughout the surgery. I mean to say the depth is really good and red glow is good. Handling microscope is also easy in the microscope itself. You can put this up and down. You can do macro focus as well as micro focus. So these are the advantages. Now you can ask, what is the disadvantage? Hello?
Yeah, go ahead.
So just I talked to the company people. Disadvantage is it is not for the beginners because of this cost factor. This is very true and reality. Though company people are standing beside me, they are raising their eyebrows. But this is one disadvantage. Otherwise, whole technical part is fantastic.
Can we focus the camera on the surgeon, please?
Hello?
We want to see you while you are talking. Now we see you.
Go ahead. You can ask.
So you were talking about the disadvantages. Is cost the only thing? Is cost the only deterrent factor for beginners, or is there some learning curve in this particular microscope, or it's as usual?
See, my personal opinion, I have gone in this field. I have spent almost 20 years of working as an independent surgeon. My suggestion for beginner also is always start with the good quality microscope, and you can use this average grade of phaco machine in the beginning. This is my personal opinion. Never compromise with the microscope quality. This is my perception. Now for me, as we are growing older, the contrast, visual acuity, everything is declining with the age. So for our age, this quality of microscope is mandatory. This is my again, I'm not biased with the company people.
So I think the best advantage in this microscope is that with the lowest